Hello everyone, and welcome to this simple presentation on approaching chest x-rays. Some of the major objectives of this presentation are to recognize adequate chest x-rays, identify all major anatomical structures, how you can approach a radiograph systematically, and we'll be covering some basic pathologies that you can find and diagnose through chest x-rays. Now, one of the first and most important things you must do when you approach a chest x-ray is taking a couple of seconds and asking some important questions that you can remember with the 5 W's. Like who? Whose x-ray are you looking at? Make sure you identify the patient with their URN and name to confirm that it's the correct one. Next is when. When was this chest x-ray taken? It's very important to note the date so you can compare chest x-rays from previous and new and see if there are any changes. Next is what? What type of chest x-ray was this? Is it an AP, PA, or lateral x-ray? And identifying the quality of the x-ray, which we'll discuss in a second. Next is where. Where was this radiograph taken? Was it taken in the emergency department, the ICU, the radiology department? It's always important to know where it was taken so you can identify what type of radiograph it is and also the urgency of it. And lastly is why. What was the indication for obtaining this image? What were the physicians who ordered this hoping to obtain? What questions were they trying to answer? When looking at a chest x-ray, you notice multiple shades of gray. And this is because conventional radiographs are limited to identifying 5 major types of densities. These densities include air, fat, fluid or connective tissue, calcium, such as calcium in bones, and metal. Now, the denser an object becomes, the more ionized radiation it absorbs, thus appearing bright on a chest x-ray or radio-opaque. Yet the lighter an item is, the more ionized radiation passes through it, the darker it appears on an x-ray, thus appearing radiolucent. When describing a chest x-ray, you use such terms as radio-opaque for bright, radiolucent for light, and you identify the different shades of gray by their density. In this example, you can look at this chest x-ray and compare the densities we discussed earlier. Here, for example, you can see that there is a metallic object, could be a button or an ECG lead, and it appears the brightest, followed by the bones of the ribs and spine, then followed by some muscles such as the heart, diaphragm, filled with blood, and then the liver would be behind the diaphragm, and then moving to the lungs, which are much more radiolucent, filled with air, appearing a little slightly darker, and then the air behind the patient himself, appearing the darkest. You've probably heard the terms AP, PA, or lateral describing a radiograph. Now, what these terms indicate is how the ionized radiation has been transmitted through the patient. AP stands for anterior-posterior, meaning that the radiation has passed from the anterior of the patient to their posterior to the receiving film or receptor. And PA is the opposite, posterior-anterior, where the radiation passed from the back of the patient to the front of the patient to the receptor. And lateral just means that the radiation has passed from the left of the patient's chest to the other side. And this is important to note because it limits how well you can read the radiograph. Now, a PA view is usually the gold standard of chest x-rays, where you would have the patient standing upright with their scapulas protracted, taking in a deep breath. And these images are much more accurate at determining the heart size. However, with an AP view, they're mainly used when patients are in too critical of a condition to stand erect, typically in locations such as the ICU or post-op or in the emergency department where the patient's possibly unconscious. And they are usually taken with a portable chest x-ray machine. You can even notice that the scapulas cover the lateral lung fields and the heart usually appears much larger. This infograph helps explain why the heart appears larger in an AP view versus a PA view. And the summary of it is, because the heart is farther away from the receptor or film and closer to the source of radiation, the shadow it casts on the image appears much larger. However, with a PA view, the patient's chest is leaning against or as close as possible to the receptor, thus the shadow it casts is more accurate towards the actual size of the heart. So let's say the images weren't labeled. How can you tell the difference between a PA or AP view radiograph? One thing I want you guys to always know is that the patient's right side will always be on your left side and vice versa, no matter which view radiograph you're looking at. However, remember, with a PA view, patients are usually standing up straight and erect, and they have their scapulas protracted. So you always expect to see the scapulas behind the thorax. And because of the way their arms are positioned, you see the clavicles over the lung fields, and the posterior ribs are more distinct. However, with an AP view, patients are usually lying down or sitting down and unable to stand erect or are unconscious on a bed. So they do not protract their scapulas, hence the scapulas appear to shadow behind the lateral aspects of the lungs on either side. And because of their arms being by their sides, their clavicles will appear above the apex, and the anterior ribs will become more distinct and easier to count. Okay. Now let's discuss the adequacy of a chest x-ray. What I mean when I say adequacy is the quality of the chest x-ray. Once you determine that you have a good quality or adequate chest x-ray, you will be more confident in your diagnosis of your patient. Now, to determine the adequacy of this radiograph, you want to remember the mnemonic RIPE. R is rotation, I is inspiration, P is projection, and E is exposure. Now, when I say rotation, remember that a chest x-ray is a 2D image of a 3D body, and if it was taken at a slightly different angle, certain anatomical structures may appear slightly distorted or different. And to determine whether you have decent or no rotation with your chest x-ray, you would want to look at the medial aspects of the clavicles and their distance to the spinous process. If you have an equal distance between both sides of the medial aspects of the clavicles, then you have a patient facing you head on. Next is inspiration. Patients need to take deep breaths in when taking the chest x-ray. And to determine whether you have adequate inspiration is by being able to count greater than or equal to 8 posterior ribs. We will discuss further how to do that. Next is projection. Projection basically implies the angulation, rotation, or magnification of the radiograph. You would want to be able to see all the anatomical structures you're looking for when looking at an X-ray. And you don't want any parts of it to be cut out. So you should be able to see all the ribs, the clavicles, the diaphragm, and everything in between, making sure that everything's in position. Lastly is the exposure. When I say exposure, I'm talking about how much ionized radiation the patient was exposed to, which can differ between how well certain anatomical structures will show. And to determine whether you have adequate exposure or not, you should be able to spot the spine passing through the heart. In this example, we can see that the medial aspect of the left collarbone is closer to the spinous process than that of the right, which means that this patient is rotated slightly to the right. Now, rotation is important to look for because it can alter your diagnoses towards certain things, such as tracheal deviation. In this X-ray, you might think that the trachea is slightly deviated towards the patient's right side, but in fact, the patient's only rotated. Significant rotation may also alter the expected contour of the heart, great vessels, the hyla, and even the hemidiaphragm. So always look out for it. This example helps show you the difference between a chest x-ray with adequate inspiration versus expiration. Here you can see that the 8 posterior ribs are labeled, and in inspiration you can count way beyond 8 ribs, but in expiration you see all the organs and the heart pushed up. Clearly, this is a pitfall when it comes to diagnosing all the lung fields and zones appropriately, as well as the shape of the heart and diaphragm and so on. Hence why adequate inspiration is important, especially in a PA view. This is an example of what a poor projection of a radiograph looks like. This is determined by the fact that you cannot see either hemidiaphragm and part of the ribs and part of the lungs is not shown in the image. This poor magnification determines that this is not an adequately projected chest X-ray and cannot be used for diagnosis. This infograph just helps determine what it means to have adequate exposure. When you expose very little, the image would appear highly bright, and certain objects, say behind the patient, might show while others won't. Yet if you expose for a long period of time, a lot of the image will appear very dark, and that affects how well you can see certain structures. For example, here you can see a tag that might be maybe in front or behind of the patient, but you can't really see the spine through the heart. And as you improve and then overexpose, you can see certain items appearing behind the heart and certain parts such as the ribs over here not appearing at all. And here is just a real life example of what underexposing versus overexposing shows. Both of these are considered inadequate X-rays. Okay, moving on to approaching a chest X-ray. After we've determined that we have an adequate chest X-ray and we've identified all of our W's, how do we read this X-ray? How do we start? Now, as you can see, there's a lot of major anatomical structures found in the chest, all of them being labeled here of over 11 things. How do I start? Where do I start from? In what order do I go to make sure I don't miss anything? Now, this is something you can approach systematically. Certain radiologists have different systems. Some prefer doing the inside-out method, others prefer going from the outside and moving inwards, and some, like many other physicians, love their ABCs. And in this presentation, we're mainly going to focus on the ABCDE approach. So after we've taken a couple of seconds to answer our W's and determine whether we have an adequate radiograph in front of us or not, we move towards the systematic approach using the ABCDE method. But before we get to the A, the first thing we want you all to look for are lines. Now, when I say lines, I'm talking about endotracheal tubes, chest tubes, nasogastric tubes, pacemakers, whatever lines that are usually inserted inside of a patient's body. Usually you can determine those by checking the patient's notes or history, or by looking at the chest X-ray yourself. Now, the reason this is put ahead of everything else is because when these tubes or lines are out of place, they usually are the most life-threatening. And it's important for you to recognize that they're all in the correct place before anything else, so that if they are not, you call the responsible physician and make sure they're readjusted. And then after we've looked at the lines, now we can start with our ABCDEs. A stands for airway, which indicates the trachea, carina, and bronchi. B is for breathing, aka the lungs, its borders and its zones. C is for cardiac, where you look at the heart, its size, its borders, the hilum and mediastinum. D is for diaphragm, where you assess the hemidiaphragms and the costophrenic angles. And then E stands for everything else. It's not our favorite, but it works to help look at bones, soft tissues, tubes or lines, again, valves, pacemakers, other devices that might have been inserted, and any particular points that the physician or the doctor who ordered the radiograph is concerned about. And for some of you who may be curious what the inside-out method is or the outside-in and what they may entail, again, after answering your W's and determining the adequacy of the chest X-ray, you start with the innermost organs, such as the heart, mediastinum, and hilum, and then you start moving out toward the lungs. You look at their zones, their lobes, their fissures. And you move to the lung borders, make sure you check the pleura and the pleural spaces. Then you move down to the diaphragm, the costophrenic angle, the abdomen, and then you move to the thoracic wall, where you start looking at the ribs, any lines and tubes, and then you move towards the outermost area, which is the extrathoracic soft tissue. Now that's inside out, and outside in is just the other way around. Okay, so let's start with A for air, which is the trachea, carina, and bronchi. When determining the airway, first thing we look for is the trachea, which is an air-filled cartilage down the midline over here. And as the trachea splits into the two right and main bronchi, you have an area in the center called the carina. So the carina is the point where the trachea splits into the right and left main bronchi. And then you can see the right main bronchi and the left main bronchi, which it's important to note that the right main bronchi is generally wider, shorter, and more vertical. And this is important because it is common that whenever someone aspirates a foreign object, especially in children, it's more likely than not to get stuck in the right main bronchi due to its shape. Here is just to further emphasize what the carina is. So we have the trachea over here, and then it splits into the right and left main bronchi. Now this angle over here, this area is called the carina. And the carina is always important to look at because it's important to note whether it's widened or not. If this angle is wider than it's supposed to be, then there's certain pathologies that can cause that. And around this area, you can also note other important structures. In the next couple of slides, we'll talk about certain pathologies you should keep in mind when assessing for the airway. And in this example, we have an obvious tracheal deviation. So like we said, the trachea, the air-filled cartilage that's supposed to go down the midline, appears to be deviated to the right side. And if we look at the medial aspects of the clavicles and the spinous process, we can determine that this patient is not rotated, so we really do have a tracheal deviation. And this is obvious due to the patient's massive tension pneumothorax here on the left side. And this tension pneumothorax is obvious because we can see a visible visceral pleura seen with this very thin white line, thin sharp white line. And we can see that there's an absence of lung vasculature beyond this line, which means that this is all air and this is all lung. And obviously we see that this lung isn't fully collapsed but is being pressured and flattened to one side, which is, and this massive air over here causes the pressure to push everything towards the right. So we can see that there's mediastinal shift, tracheal deviation to the right. Thus we have a left-sided tension pneumothorax, which is an emergency. So if you're the radiologist or the doctor in the emergency department that sees this, then you should act quickly. Here we have another slightly different example of tracheal deviation. And as you can see, we follow the air-filled cartilage, which is the trachea, and we notice that it is no longer in the midline. In fact, it's deviated towards the patient's right side. And we can also notice that the trachea is narrowed because the air is getting thinner and thinner as we go through. Now, this patient presented with a cough, shortness of breath, a slight fever, and if we look at the lungs, we know that there is no evidence of pneumothorax. That's because this trachea is deviated due to a massive goiter coming from the thyroid. So it doesn't have to be pushed by pressure or by collapse of air, but it could be pushed by other things like tumors and growths and masses and so on, and narrowed as well. So I just want you guys to keep that in mind, that there are other causes for tracheal deviation, but it's always the first thing you look for when assessing the airway. Now in this example, we talk about something called the splaying of the carina. Now remember I mentioned earlier that the carina's angle is important. Now the normal angle of the carina is usually less than 80 degrees. But when it expands greater than 90 degrees, as you see in this example, which is 105 degrees, then that is usually a pathological finding. And a common cause of why the carina would be splayed or widened, the angle of it would be widened, would be due to left atrial enlargement. Alright, that's all for airway. Next we move on to breathing. Now just to quickly recap over lung anatomy, we know that the right lung is split into 3 lobes, the superior, middle, and inferior lobe, while the left lung is split into 2, the superior and inferior lobes. Now the fissure between the superior and middle lobe is the horizontal fissure, and the fissure between the middle and inferior lobe is the oblique fissure. That's on the right side. On the left side, the fissure between the superior and inferior lobe is the oblique fissure as well. But I want you guys to keep in mind that the lungs are larger than they seem when you look at the X-ray. In this 3D rendering of the human lungs, you can see that actually the lower lobes are much larger than they are, and they actually extend posteriorly and superiorly higher than you would expect. And same goes for the superior lobes. They extend anteriorly and inferiorly, greater than you expect. So keep in mind that although you are diagnosing with 2D images, remember your 3D anatomy, remember how the lungs are divided and how these fissures actually separate the lungs, and always get a 2-view x-ray, either a PA and lateral or AP and lateral if you can, just so that you can have a better understanding of the 3D pathology and the location of where the abnormality may be. Following on the fact that radiographs are usually 2D, there are certain areas that are considered hidden areas when assessing the chest. A common obvious example is what could possibly be hiding behind the heart. Now, the heart is a large, muscular, blood-filled organ, thus it absorbs majority of the ionized radiation and it appears more radio opaque than most. So if there's any growth behind the heart or around the heart or mediastinum, it might be slightly more difficult to notice. And other common difficult or hidden areas to always look for include the apex. The apex of the lungs usually covered by a lot of bone and is hard to determine whether there's any growth or changes. Next are free air lesions that might hide behind the pleura or between the pleura of the lungs and the diaphragm, and also the hilum area, which are usually highly vascular, thus appear very radio opaque and might prove difficult to determine whether there's any lesions or lymph nodes in such areas. Okay, so just to summarize, the hidden areas that you should always pay closer attention towards include the apex, the hyla, the retrocardiac area, and the subdiaphragmatic areas. Keep those in mind, pay a closer attention to them, and if you can, obtain a second view, such as a lateral view, just to compare. Now, speaking of lateral x-rays, this is what one would look like, and they are obviously important to help provide you a different angle or perspective of the patient's chest. Now, remember, the caveat of regular PA or AP chest x-rays is that you can't really determine anterior versus posterior. You can only see from up to down and right to left. And if you do have an abnormality and you're not sure which lobe it's in or where it's hiding, it's always important to have a lateral chest x-ray so that you can determine where it is, if it's hiding, say, behind the heart or below the diaphragms, and just to have a better understanding of where the abnormality or finding may be in terms of which lobe and lung it may be. So it's always important in radiology. One of the gold standard rules is to always compare your radiographs to previous radiographs if they are available, and always obtain a second angle. These are like golden rules of radiology. Always keep in mind. If you're not sure where something is or you want to be absolutely sure, then order a lateral chest x-ray. Now that we've covered the basic anatomy of the thorax, let's focus more on some anatomy of the lung itself. Now we know that the lungs are divided into lobes that are further divided into lobules, which are formed by alveolar sacs. And in each alveolar sac, you have interstitial space that has the bronchi and vasculature and lymphatic vessels, as well as the alveoli itself, which holds air. And this is important to note because certain pathologies can be found in different parts of this anatomy. And in this infograph, we can see how the pathology is labeled differently and represents on a chest x-ray differently depending on which anatomical structure it's affecting. For example, the consolidation, which is basically any pathological process that fills up the alveoli with either fluid, pus, blood, cells such as tumor cells, or any other substances, may result in diffused, lobar, multifocal, or ill-defined opacities in certain areas, in certain lobes. So those are the terms usually used to describe such consolidations found. You would describe it as diffused or multifocal, ill-defined, lobular, lobar, and so on. And then it's up to the pathology team or the diagnosing team to determine what could possibly be filling up the consolidation. Because as we know, fluids such as blood or pus will have a similar density to one another, and you can't really determine that on an X-ray. Moving on to interstitial findings, which is involvement of the supporting tissue of the lung parenchyma, which will result in fine or coarse reticular opacities or small nodules. So when the pathology itself is in the interstitium, the area between, or the septa between the alveoli, you will get more linear line, sort of scratchy findings, and they're described as either coarse or reticular opacities, and sometimes they can show up as small little nodules. However, if you have like a tumor or a mass, you can have nodules that are like space-occupying lesions that are solid, maybe even multiple. Or you could get atelectasis, which is the collapse of a part of a lung due to a decrease in the amount of air in the alveoli. So these air-filled sacs that are alveoli might be collapsed for some reason and decreased in volume, and when they decrease in volume and collect together, they get denser, and when they get denser, they appear more radio-opaque. So these are some examples of the pathologies, and we'll go over them in the next following slides. So again, just to familiarize yourself with what a normal chest x-ray looks like, here you see an adequate chest x-ray of a female patient with a decent amount of inspiration and lots of vasculature in the lung, but otherwise you'd go over it in the systematic approach we're discussing currently. But to basically determine the lungs itself, we divide the lungs into zones. Now the upper area is called the upper zone, middle area is the middle zone, and then the lower area of the lungs are the lower zones. And you'd usually look at the upper zones together, compare them with each other, pay closer attention to those hidden areas we discussed, and move on to the middle and move on to the lower. After you do that, you would want to look around the borders of the lungs to determine the parenchyma and make sure they're all in place. And then you check the diaphragmatic areas, the connections between the parenchyma, the pleura of the lungs and the diaphragm, looking at these angles over here called the costophrenic angles. And here we have different examples of certain consolidations or interstitial findings, atelectasis, and even some masses and what they would look like. Feel free to pause the video and identify them yourself, but you would notice that they would appear as either diffused, multifocal, opacities. They could be ill-defined, they could be very obvious in the different zones of the lungs. And when you describe them, make sure to identify which zone and which side of the lungs. Remember that we are always facing the patient, so our left side is their right side and our right side is their left side. So don't confuse the two. And it's always helpful to look at any radiological markers that might be there to make sure you're identifying the appropriate side when describing the radiograph. Now, some key examples I've included in these slides are to help you guys familiarize yourself with these findings. And in this example, we have a obvious, large, right-sided lobar consolidation. Now, I would normally want you to be more specific when describing this. So I would want you to determine which lobe of the right lung would this consolidation be in. And if I were to ask you, I would assume most of you would say that this is in the middle lobe of the right lung. However, this is actually in the upper lobe. This is an right upper lobe consolidation. And that's a common mistake that happens by medical students and younger doctors because they forget that you are looking at a 3D object in a 2D view. And although it may appear in the middle lobe, you can't see the horizontal fissure on top of the consolidation, but rather in the bottom of it. So the consolidation actually cuts off more horizontally here, and that means that this is all in the upper lobe. If it were to go straight and then grow below, then it's more likely in the middle lobe. And in this example, we have another right-sided lobar consolidation. And I want you to know that it's okay if you cannot directly determine which lobe the consolidation is in. And if that is something you struggle with, the best you can do is take the time to describe the consolidation. And one of the important factors to determine is which zone it's in. So if you remember, we said there's an upper, middle, and lower zone of the lungs. So the best you can do is just, for your OSCE, for example, describe that it's in the lower zone of the lungs. And other ways you can describe it is you can say that it's maybe ill-defined or diffused, lower lobe, right lower lobe consolidation. And another important factor I want to mention here is that if you notice the right-sided border of the heart, it's very difficult to determine because the consolidation is either right on top or behind of the heart. And this effect over here is called silhouetting. So here you will have an example of a consolidation silhouetting the right border of the heart, making it difficult to see and difficult to determine. So keep that phrase in mind. And here we have an example of an alveolar opacity. And I want you guys to pay close attention to that sort of cotton ball effect that alveolar opacities demonstrate. And that is because if we remember the anatomy of alveoli, there are these sacs that have sort of a grape-like appearance, and when they get filled with a denser material such as fluid or pus or blood, they tend to appear more radiopaque but still hold the anatomical appearance of little balls and grape-like cotton ball sort of effect. And here we can see as side by side, on the left side we have normal lung, and on the right side we have this sort of diffused alveolar opacity covering majority of the middle and lower zones, as well as part of the lateral upper zones of the right lung. Another effect I want you guys to keep in mind when looking at abnormal radiographs is something called air bronchogram. And an air bronchogram is basically when air-filled bronchi are being made visible by an opacification of surrounding alveoli. So if you look at the middle zone of the left lung of this patient, here we find these black sort of streaks happening. They have this sort of effect like the image on the left, where because the surrounding area is more opacified and appears brighter, then we can see that the bronchi that are not filled with anything but air start to appear, and that's called an air bronchogram. Now, when it comes to interstitial pathology, there are a lot of different terms used to describe the findings you may see in a chest x-ray. These are slightly more difficult to pick up on, especially the differences between them, and I don't expect you to know them by heart or be really good at picking them up, because a lot of people struggle with them, but you just need to know what's happening. But basically, the interstitial space between the alveoli and lobes of the lungs and the septi basically have some certain pathologies, whether it's inflammation or edema, and that causes different patterns to appear. Here on the top left, you can see what a linear pattern looks like. It just appears like streaks or scratches, and it can also appear on the border of the lungs. Here we have what we describe as reticular findings, which appear slightly curved. Nodular, from the word, are sort of dotted, and then reticulonodular are both dotted and curved. Interstitial pathologies. But just know that if you do see streaks such as these, then what you're looking at is an interstitial pathology. And from there, you can move on to diagnosing your patient. Now, how these interstitial pathologies are defined radiologically usually fall under either curly A, curly B, or curly C lines. There are other terms as well, but these are the common ones I want you to know, specifically curly B. But with curly A, you usually have 2 to 6 centimeter long oblique lines, less than 1 millimeter thick, that course towards the hyla, and they usually represent thickening of intralobular septi. With curly B lines, they're usually 1 to 2 centimeters in length, and they're in the periphery of the lungs, as we see here in the picture. And they're perpendicular to the pleural surface, and they extend out towards it. And they represent thickening of subpleural intralobular septi, and are usually seen at the base of the lung. And then there are also curly C lines and curly D lines, but the ones I want you to mainly know are curly B lines. Now, sometimes diffused complex interstitial diseases can have this sort of fishnet pattern to them. And this is just an example for you to recognize that on both sides of the lungs, there's diffused reticular interstitial fishnetting sort of pathology. And sometimes you may look at a radiograph and you can't really determine what sort of pathology. Is it alveolar? Is it a consolidation? Is it interstitial? It sort of has a haphazard appearance to it. And that is commonly seen in asbestos. When a patient has been exposed to asbestos and it causes lung pathology, it would appear sort of haphazard and it will be difficult for it to fall under any of the descriptions previously discussed. So this is just an example for you to keep it in mind when you can't describe it, then to look back at the history and see if you can determine whether this patient has had any exposure to asbestos or so forth. And I know we more or less discussed this previously when talking about tracheal deviation, but when it comes to determining pneumothorax, it usually falls under the breathing section of your ABCDEs. And I want you guys to pause the video and try to determine which side the pneumothorax is on. And once you've done that, I can tell you that there is the pneumothorax is in the upper zone of the left lung. And I know this because I can see that thin solid white line we discussed, which is the pleura of the lungs, and I know that there's absence of pulmonary vasculature extending beyond that line. So I know that this area is all filled with air and it extends all the way to here, and that this patient has a pneumothorax. Okay, moving on to the third portion of our systematic approach, we got to C, which is cardiac. And with cardiac, we look at the hilum, mediastinum, and the sides of the heart, as well as the cardiac shadow. Now, going over some of the basics of cardiac anatomy, we know that the orientation of the heart means that the different borders that appear radiologically indicate different parts or different chambers of the heart. So when we look at the right border of the heart, we know it's mainly formed by the right atrium. The posterior border is mainly the right ventricle. The left border of the heart is partially the left ventricle and slightly partially the right atrial appendage. Now, when we look at the hilum, we know that coming here on the right side is the superior vena cava, and it causes the right border of the hilum. And on the left side, we have this sort of area where the aorta goes from its arch to its descending form, causing this sort of bend, which makes a radio-opaque part called the aortic notch, and the descending aorta causing the left border of the hilum. And here is an example of a normal PA heart, and we're trying to determine whether this heart is enlarged or effused. And we do this by looking at something called the cardiothoracic ratio. And this ratio can be found by measuring the borders of the heart, the distance between the right and left border of the heart, and the borders of the thorax. And as long as your cardiac borders equal to half or less than half the thoracic borders, then you have a normally sized heart. And once it's greater than half, then you can determine that this heart is an enlarged heart, and you need to spend more time finding out why is it enlarged. Is it cardiomegaly, or is there a cardiac effusion, and so on. And in this example, you can see what cardiomegaly would look like on a PA radiograph, and just by eyeballing it, you can tell that this heart extends beyond half of the size of the thorax of this patient, which means there is an enlarged heart. And I know I've mentioned this before, but when you get to the portion of C in your ABCDEs and you're looking at the cardiac, you would want to determine the cardiac borders. And like we said in that previous x-ray, here we can see that there's a complete absence of the right cardiac border, and that is what we call the silhouette sign. Now, remember that the silhouette sign is somewhat of a misnomer because it simply implies the absence of the cardiac silhouette against the lungs. But it's always something important to note for so you can understand the pathology of what's going on. And now we've approached the D portion of the ABCDEs, where we look at the diaphragm, its domes, and its angles. Some key points I want you guys to keep in mind when looking at the diaphragms is to note that the right hemidiaphragm is almost noticeably always higher than the left hemidiaphragm, and that's due to the presence of the liver over here. And in the left hemidiaphragm, it's common to see this radiolucent finding, which is basically some air, and it's known as the gastric bubble. It's just some air in the stomach found right under the left hemidiaphragm, and it's considered a normal finding. Now, a common reason we look at the hemidiaphragms is to determine whether there's any pathologies or not. And even though we're looking at a chest x-ray, there might be some abdominal pathologies that we can find from a patient who took an erect PA radiograph. And in this case, it would be finding some air right under the diaphragm. If you look over here on the right side, on the right hemidiaphragm, there's a clear radiolucent line that goes right between the border of the diaphragm and the liver, and can also slightly be seen here on the left side. This is known as pneumoperitoneum, and it's usually due to some sort of gastric puncturing that led air into the abdomen that floated up towards the diaphragm if the patient's standing upright. So even though the patient got a chest x-ray, it's always important to look for the diaphragm, or this is one of the common findings to look for when looking at the diaphragm, to determine if there's any pneumoperitoneum. Another important finding or pathological abnormality that you can determine when looking at the diaphragm is not seeing the diaphragm at all, such as in this case where there is complete absence of the right hemidiaphragm, and that's due to this radio opacity which has a density of fluid blocking our visibility of the right hemidiaphragm, more or less. And when you have this sort of curved line going this way, this is described as a meniscus, and that's a common finding in pleural effusion. Now, it takes about 175 ml of pleural fluid to be able to visualize it on a PA image as a meniscus in the costophrenic angles. Sometimes it doesn't have to appear as a meniscus, but it could completely block this costophrenic angle, which is the angle between the curve of the diaphragm and the curve of the costal border of the thorax. This angle over here might appear full with or more dense with fluid, and that's usually a sign of pleural effusion. Now, this is obviously a more exaggerated example, but it's important to know. And also note that it will appear, pleural effusion will appear on a lateral X-ray with only 75 ml or more, and it has to be over 500 ml for it to appear on a supine chest X-ray. So obviously this patient is standing upright, he's erect, and that's why we get that meniscus effect. It will be a little different if he was lying down, but this is a PA radiograph, and hence why gravity causes this sort of meniscus effect in pleural effusions. And speaking of costophrenic angles, usually you describe them as blunting of the costophrenic angle when there is fluid filling up that space between the diaphragm or hemidiaphragm and the costal margin of the thorax, whereas here it will be considered normal, and when it's normal it's described as sharp costophrenic angle. Last but not least, another abnormal finding when looking at the diaphragm is having flattened diaphragms. As you can see, you cannot clearly distinguish the difference between the right and left hemidiaphragm. They appear at the same line and they appear flattened, and the costophrenic angle isn't as sharp as it's supposed to be, but it's also not filled with any opacity. Now, this can be due to hyperinflation of the lungs. It could also be due to pneumothorax, and it can also be seen in a lateral chest x-ray. Moving on to the final and most filled portion of the ABCDE method, which is everything else, starting with bones and soft tissue. Now, I want you guys to take a second to pause and pay close attention to what this infograph is trying to tell you, specifically when it comes to counting the ribs, because there's a difference between counting anterior ribs and posterior ribs. And that falls behind the fact that, if we remember, a chest x-ray is a 2D image of a 3D object, and we know that our ribs curve from backwards forwards pointing downwards. So they come from posterior to anterior inferior. They just have that downward sort of pointing effect. And when we see both sides of that in a flat image, it can get a little confusing on how many ribs are on either side. So choose the method you prefer, and there is a difference between counting posterior and anterior ribs. But if you look here on the left, you can see anterior ribs are the ones pointing downwards. They go this way, and you usually start with the first rib and count your way downwards to make sure that these are the anterior ribs. And again, you can also follow it all the way from the back and move forward just to know exactly which rib you are by looking at the vertebral body it's coming out of, just to be sure. And if you see it coming sort of upwards or horizontally, then those ribs are the posterior ribs, and they go all the way down this way. So this is actually the anterior portion of the sixth rib going all the way down here, and you can see it over here as well. So when it comes to everything else, we start with our bones and soft tissue portion. So we would want to look at every single rib and identify if there are any fractures, any cracks or breaks. Always important to follow every single rib down either side. And you can also look at the spine and count the thoracic spines, look at the clavicles, make sure there are no fractures and there's no discontinuation amongst the cortex of the bone. You can also assess for the scapula. Now, rib fractures are a little difficult to assess, especially if you rush through a chest x-ray without following it systematically and taking the time to do every single step. It would be nice if you guys pause at this section of the video and try to tell me where the fracture is. And once you've done that, then you would be right if you said that the rib fractures are on the left side of the patient. There's left-sided 3rd to 7th rib fractures, with 6th and 8th rib fractures displaced. There's no pneumothorax or pleural fluid found collecting in this patient, but most of the time you would expect to find such abnormalities as well. And the last portion of the everything else was reviewing what we said initially was the most important, which are the lines, tubes, and pacemakers. Normally, you'd look at those first, make sure they're in place, go through your ABCDs, and then go over them one more time with a more thorough eye. So, some of the most common tubes that you will see are endotracheal tubes. Now, these tubes are made of plastic and are usually inserted into the trachea, so they appear more radiopaque. However, they also have this metallic filament that indicates where the tube is, and most importantly indicates where the tip of the tube ends. And this is something you should always note for, because you should always identify the tip of the endotracheal tube and make sure it's about 2 to 5 centimeters above the point of the carina or at the level of the aortic arch. Now, this is very important to note because sometimes it can go in too deep and end up in one of the main bronchi, most commonly the right main bronchus, and it's something you want to look out for first and make sure you note it and point out that it's in the right position or in too deep so that it can be pulled back a little bit. Next is the nasogastric tube, which is a tube that goes through the nose, down the esophagus, and into the stomach. And obviously it is radiopaque, but the most important point for you to follow and find is the tip of the tube. You want to make sure that it goes beyond the diaphragm and into the stomach, preferably the fundus of the stomach where the gastric bubble is. Because if it goes down the trachea, down the wrong tube, it will end up into the lungs, most commonly down the right bronchus and into the lungs like this image here on the left. And it can be very, very detrimental and a horrible, horrible thing when the nasogastric feed goes into the lungs instead of the stomach. So whenever a nasogastric tube is inserted, an x-ray is usually ordered, and it's your job to determine first and foremost that it's not down the wrong tube. Another important tube to always keep an eye out for is a chest tube. These are usually administered by emergency department physicians, and they're put through the sides of the patient's chest right under the armpits. And they also here, as you can see on the left, have a radiopaque line that goes through them, but the line also has like skips in it. And these skips are because these are holes in the chest tube on the side that help drain whatever it is the physician is trying to drain, whether it's air or fluid. But it's always important to determine where the tip is, making sure that it's actually inside the lung and not being dragged dragged out by the patient or slowly trying to escape from the thoracic cavity. And to make sure that the holes are visible, it's not right under the skin. If it's right under the skin, then there would be air sort of leaking into it under the skin. So it's always important to determine that it's in the right place and it's not sort of escaping. Next is a device that you might see in a couple of chest x-rays, especially in senior patients, which is a pacemaker. Now, pacemakers are usually made of metal, so they appear very radio-opaque. You can see all the wires and technology inside of it, and you can see the wires going all the way into the heart. It's important to note them. Note that you see them during an exam situation, or even when presenting this case to your attending or examiner. Always mention the things you see in front of you. That's how you get the points. That's how they know that you're going through it. But make sure you go through it systematically. Don't look at it first. Go through everything systematically, and this is part of the end of the systematic approach. Now, obviously, I've hand-picked out all these images to show you exactly what I wanted to show you. But in reality, chest x-rays can be very complicated or very overwhelming to look at. You might see a lot of lines and a lot of changes and you have no idea where to start. So it's always very important to ask your W's, go through your RIPE, and then go through ABCDE, follow everything systematically. It might have taken me almost an hour to explain every single part for you guys, but reading a chest x-ray does not take that long. And then once you're done, you put it all together. And once you do, you're ready to put it all together. You start with your W's, you talk about the type of radiograph you're looking at, who it belongs to, how old the patient is, when this radiograph was taken. You can even include where or why, the indication behind why this radiograph was obtained, and then you just follow the system as discussed. You go through A, airway, we're looking at the trachea, you make sure the trachea is central, the bronchial trees are appearing normal. B is breathing, we're looking at the lungs are clear in all zones, the pleural spaces are free. C, we're looking at the heart, the cardiac and mediastinal silhouettes appear normal, there's no cardiomegaly. You're looking at the diaphragms, diaphragms also appear normal in this patient. And then E, we're looking at bones and soft tissues and lines and devices, and they all appear normal or not available. So your impression at the end of all this, the summary of it all, is that this is a normal chest x-ray. Now, if you go through the PDF of this lecture, I've included a bunch of normal chest x-rays for you to look at. Feel free to take your time, go through each of them systematically, and write down your reports as practice. And then later in class, we'll go over some cases together with some pathological findings of the most common things you might see, and we'll report them together systematically, and we'll answer any questions you guys have. Thank you for taking the time to attend this presentation. I hope it was informative. My email is in the first slide, so if you have any questions, just feel free to reach out at any time. I'd be happy to answer them. Have a great one.